Okay. Good morning, all faculty, the co-chair, Dr. King, and all the colleagues in China, or all the participants around the world for this webinar. It's my honor to be very happy to announce the beginning of the webinar called New Horizon of Y90. Yeah, I'm very happy to co-moderate this session with Dr. Eddie King. So this morning we'll have three speakers. The first speaker is Dr. Wayne Mallet. He will present the science background of the Y90, and the Dr. Mallet comes from the Boston Scientific. Dr. Eddie King from Mount Sinai, he will introduce the clinical update of for HCC and Y90. And the last speaker will be Dr. Sandy Marine. He comes from Northwestern University, Chicago. Who will introduce some new application of Y90. HCC or metastasis of the liver metastasis in China still a big problem. Last year, the HCC, the second, the rank of the mortality in China. I mean the 39,000 of people died of HCC last year in this country. So the interventional oncology procedure is very important, especially like tests in China last year. I believe they performed more than 500,000 such procedures, but still increased, and with the other procedure like ablation and also, the similar but different. We have lots why, adding 125, also to see that to apply in the liver tumor still. So the Y90 coming to this country is a very good news, but it really spent a long time, more than 10 years. It's quite early to approved by FDA, but China still, either Boston Scientific or the BTG still on struggle for the Chinese FDA now, Chinese FDA. But good news, they will be coming to this either Certex or Celis Fair. They will be coming to this country finally. So for our intervention radiologist, for all physicians around the Y90 in this country should be make a preparation. So such session of the dedicated to Y90. So it's very important, very useful for our application in the near future. So I would like to thank you all the faculties, and especially I would like to thank you Boston Scientific to sponsor such an important session. So I wish this will be successful presentation and the sessions. So Dr. Kim, do you have any?
I think it's truly an honor to be here and to be a part of this event. Thank you to Boston Scientific for allowing us to discuss Y90 and its future applications and its current technology and studies that are out here with our colleagues in China. And so I will start it off and introduce Wayne Mullet, who has been integral to the development of TheraSphere from the start, and probably a huge load off of his back with recent FDA approval for the treatment of HCC with TheraSphere. And it's the only approved device in interventional radiology for the treatment of HCC. And so Wayne, please take it away.
Great. Well, thank you very much, Dr. Kim and Dr. Tang. Appreciate your effort to co-chair this session. and of course, Dr. Mooley for co-presenting today as well. And obviously want to thank the Society of Interventional Oncology for this opportunity to talk a little bit about the science behind yttrium-90. And specifically, I'd like to walk the audience through the use of radiation in cancer treatment and how yttrium-90 microspheres can help treat liver cancer. One of the things I would also like to go through would be kind of an overview of what some of the critical quality and clinical attributes are with Y90 microspheres, so you can help better understand the way the technology works and how you can use this approach to achieve better patient outcomes. So just moving on to the slide here. So before I jump ahead though, I would like to talk a little bit about kind of what the objective is when we think about treatment of cancer and what's most important. And I think that's captured well in this quote from the American Association of Clinical Oncology, and the fact that oncologists have always strived to be able to find more powerful therapies, combination and dosing regimes that can maximize effectiveness and minimize side effects. I think we can all very well appreciate the fact that cancer is a very difficult and diverse disease to treat. So anything that we can do to be able to optimize and improve dosing, to be able to find more powerful therapies which optimize that and increase the effectiveness of those treatments and minimize the side effects will be very critical. One of the ways that we can achieve that is with a technique called transarterial radioembolization, or TARE, also known as selective internal radiotherapy. And the working mechanism behind transarterial radioembolization is shown in the schematic down here at the bottom. What you start off with are glass microspheres, or a microsphere which have the appropriate size and shape. There's this picture of a scanning electron micrograph to give you some size perspective. And these microspheres are of the appropriate size and shape that they can be delivered through the hepatic artery via a catheter, where they become trapped at that precapillary level and emit the lethal internal radiation. I think what's very important to recognize as part of transarterial radioembolization, that the mechanism of action with this treatment is radiation. The microspheres are really just there as a carrier to bring that radiation selectively inside the actual tumor. I think a great example, and this is some very early data that was published in the Chinese Journal of Nuclear Medicine dating back to 1992, which shows the effect of dose and the proportionality of dose to treatment outcomes is shown very well in some of these early experiments where we have cancer xenograft on mice. And as we look at the control animals shown here in A and move from left to right, what we see is an increasing amount of radiation that's being deposited into the tumor. And you can see a direct proportionality in terms of that tumor control as we increase the amount of radiation dose that's being subjected to the tumor. So recognizing that radiation can be used and has been used for a long period of time in the treatment of cancer therapy, what is really, why is it used and how does it actually work? The schematic or the cartoon shown up here on the top right gives us an indication of how we can use the high ionizing energy from a radioisotope. In the case of Y90, that would be a beta particle, which has a high energy, and either through direct or indirect interaction, it can cause cleavage of the DNA strand. And if that ionizing energy can cleave the DNA strand more times than the cell can repair it, then we have an opportunity to be able to shut down cellular replication and effectively control tumor growth. There's different ways that we can do this. The most common one, of course, is with external beam, where you bring the radiation source from the outside and penetrate it through the body inside to the tumor's tissue. That has some limitations, which I'll show in the next slide, around how much absorbed dose you can get to the tumor due to the collateral damage or potential collateral damage that happens as that radiation passes through the body. You can do things like systemic therapy, where we tag an antibody which is selective for a specific type of cancer with a radioisotope. Of course, this requires a very selective antibody, and there is potential for off-target effects. And maybe the more straightforward approach is basically what I just described, where we look at targeted deposition using a radioactive microsphere, which are directly deposited inside the tumor. Once again, kind of highlighting the proportion or the direct relationship between dose and tumor control. Here's a graph which shows that that effect with external beam. And what we see here is on the x-axis, as we increase that dose, we can see a direct relationship to tumor control as indicated by the red line. Unfortunately, what happens, of course, is that high ionizing energy from the radioisotope, it doesn't differentiate between a tumor cell and normal cells or healthy tissue. So we can also see a direct relationship to normal tissue damage as we increase dose. So anything that we can do to shift that blue-green line to the right and be able to increase the dose that the tumor experiences will be highly beneficial. And this will give you some perspective of the type of doses that we can achieve with various different types of radiation modalities, starting off again with external beam. And as I mentioned earlier, because of the potential for collateral damage, it's fairly limited to the amount of absorbed dose that the tumor can experience. When you get into Y90 radioembolization, you can see, because of the fact that we're using preferential blood flow to the tumor, we can increase those the amount of dose that tumor experiences, and specific to the glass microspheres, which I'll talk a little bit more about in a moment, because of the high specific activity, the amount of radiation that the microspheres carry on board, we can get an even higher dose again. So recognizing the value of using radiation to be able to control cancer cells and the ability to be able to include that into a microsphere, how do we go about developing a high quality and clinically relevant transarterial radioembolic product? Well, like any type of medical device or pharmaceutical product, it always centers around efficacy and safety of that device. And once again, similar to my earlier comments, you're always trying to obviously optimize, increase that efficacy, and downplay any type of safety or adverse events. So I'll kind of walk through some of these fairly quickly, but when you look at the design of the product, which type of isotope you use, the amount of isotope that you have on each of the individual microspheres, effectively what we refer to as a specific activity, the stability of that particle. We want the radiation to stay inside the microsphere, which is being deposited inside the tumor, the size and shape. And of course, obviously, it's very important from a user perspective that you're able to prepare that effectively and get that dose delivered inside the tumor. So in terms of the selection of yttrium and why we see this as a very powerful isotope to be able to use for tumor control, I have a table here, which I won't spend too much time on, but it highlights the different types of radionuclides which have been used in cancer therapy and their emission profiles shown on the left-hand side. So you have things like OJ alpha, or in the case of Y90, it's a high energy beta emitter. We can see the respective half-lives of each of these isotopes, their energy, and their penetration range in tissue. And when you look through these, you can see that yttrium-90 specifically has a very high energy, which is required to basically cleave up that DNA strand and help control tumor replication. It also has a fairly good penetration distance as well, so you can get a so-called crossfire effect. So you can basically get overlap of that tumoricidal diameter across the two different microspheres. The half-life of the isotope is also very helpful from the perspective of being able to manufacture it and handle it. So how do we get that, since Y90 is such a good isotope, how do we actually get that inside of a glass microsphere? One of the ways that we do it with TheraSphere is we combine very high purity starting reagents, silica, aluminum oxide, and what will become the yttrium oxide. That will be the key active ingredient. We're able to melt those together at a very high temperature to get a homogeneous mixture. We sphericize those, and at this point, of course, they're just glass microspheres. So by adding or placing those into a nuclear reactor, we can convert the stable form of yttrium into the radioactive form to give it its potency. And because we have such a high level of yttrium oxide, we can get to a very high activity per microsphere, which minimizes the number of microspheres you need to use, which minimizes the risk of stasis. My lights just went out. I hope that's okay. Once again, just ensuring the stability. There's a lot of development work that went into selection of the glass microsphere, ensuring that we have a high stability product. And that's actually been shown here in the bottom graph when we look at the some data from in vivo. This is post-administration of the Y90 glass microspheres, either thermosphere or Ceraspheres, and the collection of the amount of free Y90, which is observed in the patient's urine. And you can see with Therasphere, because of the fact that the yttrium-90 is stably incorporated inside the glass, it's very much contained, and you see a very negligible amount of the Y90 leaching away from the product. And this is obviously very important because you want to ensure that the product stays inside the glass, which stays inside the tube. One of the other important parts is recognizing that oxygen is a very potent radiosensitizer. So when you're depositing these microspheres inside the tumor, the importance of blood flow is actually shown here in this graph on the right. And what we can see in terms of that surviving fraction, if you have an aerated tissue where there's still blood flow, you basically see a much improved or a much less dose, which is required to be able to kill the actual tumor cells. And the angiograms on the bottom kind of highlight that as well too, where we can see the initial tumor blush, pre-administration, post-administration, 45 days later, we can see that blush has disappeared as we've been able to effectively treat that tumor, but we still have patency and blood flow through that region, which also allows, once again, for the potential retreatment of this liver of either glass or Y90 or other liver-directed therapies. So once again, because we have that high level of yttrium-90 inside the glass microspheres, we have a very high specific activity. We're able to provide a very long shelf life, which enables a wide range of dosing and personalized dosing options over the 12-day shelf life. And because of that high specific activity, we're able to deliver a very high radiation dose to the tumor. And I think one of my last slides here helps highlight the effect and the importance of that high dose to the tumor. And this is data which was generated by Professor Garan at Rennes. And what he looked at was modeling, and I think Dr. Kim will talk a little bit more about this in his presentation as well. He looked at stratifying two groups of patients, those who received a low dose to the tumor, less than 205 gray, versus those who received a very high dose to the tumor, greater than 205 gray. And what you look at is as part of the median overall survival, is you can see a very dramatic difference for those patients who receive that high dose to the tumor. So in this case, when you're talking about greater than 205 gray, we could see 27 months of survival versus slightly less than 10. And in the case of portal vein thrombosis, that effect was even greater, similar, median survival of 24.5 months versus five months for those patients who received a low dose to the tumor. So just to conclude and wrap up here, I just want to give you a quick highlight and overview of the two Y90 radioembolic products which are out there, the glass microspheres, Therasphere, and the resin ones, which are Ceraspheres. One is obviously glass, the other one is the surface bound, the yttrium-90 surface bound through an ion exchange resin. Fairly similar size in terms of the particles. The big difference, of course, is the specific activity with the glass microspheres because of the way that they are made to have a much higher activity per microsphere, which enables you to get that much higher dose to the tumor and minimize the risk of stasis, which is shown in terms of the population or the number of microspheres per vial being much less with Therasphere versus Ceraspheres. Density is a little higher for the glass product. The other additional features, I guess, or differences between the two products is the glass microspheres are sold pre-ready, already dispensed according to the patient requirements, which means that they're ready to use. The administration time is a little bit less with Therasphere versus Ceraspheres. So just in final conclusion, I hope you have a better appreciation that the goal of internal radiotherapy should be to maximize the amount of dose that the tumor experiences while limiting that toxicity. And the glass formulation provides a maximum radiation dose to the tumor with a very minimal embolic effect that minimizes stasis and reflux. And because of the way that the product is made and that high activity that we're able to deliver to the tumor, there's a very high chemical and physical stability as well that help provide for better outcomes. And that is it for me. I guess we'll save the questions for the last.
Yeah.
I'll turn it over to Dr. Kim.
Yeah, thank you very much, Dr. Wen. Dr. Moretti, I just know will be a discussion after all talks. So let's move next speaker, Dr. Eddie Kim. He will talk about the clinical update of the Y90 for liver cancer. So please, Dr. Kim.
Thank you, Dr. Tang. Again, it's a pleasure to be here, and thank you to SIO for the invitation to speak for this event. I'm going to now transition from Wayne's excellent talk on the basic science of TheraSphere and its glass formulation in Interim 90, and really talk about how this applies in terms of clinical medicine. How do we utilize this technology for the treatment of HCC? And this past year has been an incredible year in terms of data that's been published, as well as the US FDA approval for the treatment of HCC with TheraSphere. These are my disclosures. So that everyone is on the same page, this is a modified BCLC staging system and treatment strategy from 2018 with EASL and the American Association for the Liver Disease. And you can see here that in the early, intermediate, and the advanced stage, that we can use radioembolization throughout the BCLC staging system. And we're going to talk about three, I think, very up-to-date and important studies that really highlight this objective. The first study is really the legacy study. The legacy study is named for the local radioembolization using glass microspheres or TheraSphere for the assessment of tumor control with Y90. And this was a retrospective single-arm multi-center study within the United States at 3 centers, Northwestern, Mount Sinai, and University of Washington. And what we did was we looked at our data in consecutive patients treated with Y90 glass microspheres between 2014 and 2017. There was a median follow-up of close to 30 months in this patient population. And we wanted to assess local tumor control, objective response rate, as well as duration of response, which has been published with all of the phase 3 randomized controlled trials with systemic therapies in the advanced stage, the latest being IMbrave 150. And this was all patients treated with glass microspheres in unresectable and solitary HCC. So what made up the population of legacy study? You can see that it ranged in age from 18 to older than 75. Older than 75 was about 18% of the patient population and included early and as well as advanced stage. The advanced stage was really based on ECOG performance status of 1, which is about 40% of the patient population. And you can see that that reflects in exactly the numbers between ECOG status 0, 1 and BCLC stage A and C. The median tumor size was about 2.6 centimeters in size, but it ranged from 1 to about 8 centimeters in size. And the initial goals ranged from curative intent to bridging downstaging to ultimate therapy. The thing that was interesting in this study is that the absorbed dose to perfuse liver volume was in excess of 400 gray, 410 gray to be exact for this study. When you look at the time to event outcomes, you see that the time to progression, percent of patients without localized tumor progression at 24 months, according to localized modified RECIST, is an astounding 100%. And that means that all those patients had no progression according to modified RECIST. And when we talk about local regional therapies and treating HCC, modified RECIST is well established as the global standard for assessing local regional therapy. If you look at the progression-free survival at 24 months, you can see that 94% of the patients have progression-free survival at that 24 months, with local recurrence rates for the whole study being about 5.6%. When you really focused on the results of legacy, the objective response rate based on a blinded independent review, centralized review, or BICR, we're talking 88%. Now, Y90 or radioembolization is a little bit different, as Wayne discussed, as opposed to chemoembolization, where with chemoembolization, you're injecting a drug and occluding the vessels to destroy tumor. However, with radioembolization or radiation segmentectomy, you're injecting a high dose of radiation into a perfused area. And those spheres that are embedded with Y90 will emit radiation over a period of time. And you're not trying to occlude those vessels, but in a way seed those vessels with radiation spheres and letting the radiation then do all the damage to the tumor and the surrounding tissue. When you look at the duration of response, greater than 6 months in time, it was 76% of the patients. And 97% of patients attained a best response after one treatment with Y90 or based on localized modified resist. How about in terms of keeping performance status or attaining within the Milan criteria? At 24 months, you saw that 82% of the patients maintained their ECOG performance status, and that 85% of patients were within Milan criteria and were able to be transplanted. In the United States, for instance, in New York City, where Mount Sinai is located, it typically takes patients 2 years to get a transplant with HCC T2 points. And so this is an important tool for interventional radiologists within the United States to bridge patients potentially to transplant. But we're finding out that in this select patient population with solitary hepatocellular carcinoma, that it can indeed be a curative response. And so the legacy study demonstrated that radiation segmentectomy with glass microspheres can be used as a neoadjuvant therapy prior to transplant resection or as a standalone treatment for a curative intent, and supports the use of a very high dose of radiation greater than 400 gray to the absorbed dose for maximum outcomes that are safe. And this is just an example that I wanted to show from our experience with a pre-radiation segmentectomy on the left, where there was a 5 centimeter HCC in segment 4. And then on follow-up, this patient had a complete response according to modified RECIST. The labs, the liver function tests were unchanged, and the AFP dropped to within normal limits from an original start of 600. This patient was then transplanted 5 years later. Because he did so well with radiation segmentectomy for this 5 centimeter tumor, that he held off on transplant for that long. And that 4 years, when he started developing sites of HCC in areas that were not treated with radiation segmentectomy, he decided to go back on the transplant list and was eventually transplanted. And the transplant showed that there was complete pathologic necrosis of this 5 centimeter HCC on explant pathology. The next study to talk about is the TARGET study. So the TARGET study stands for TheraSphere Advanced Dosimetry Retrospective Global Study Evaluation in HCC Treatment. This was a retrospective single-arm study in 8 countries and 13 centers with over 200 patients that were treated between 2010 and 2017. And the goal of this study was to look at software, in this case, the Murata Simplicity software for co-registration, segmentation, and dosimetry, to really see if dosimetry can be standardized with this software. The key eligibility was liver dominant disease with or without portal vascular invasion, up to 10 HCCs per lobe. At least one had to be greater than 3 centimeters in size, Child-Pugh A, B7, and included all stages of BCLC except for D. So A, B, and C were all included in this study. And with this study was different from the legacy study, which was a selective injection of radiation into a Cunode segment. This was a lobar administration of TheraSpheres, either left or right side. These are the sites and investigators. You can see multiple centers throughout the globe that were included in this study. Again, the primary study objective was to collect clinical data from all these sites, real world data to look at the relationship between tumor and a normal absorbed dose, and to see if there is any adverse events as well as objective response in HCC patients across BCLC A through C treated with glass microspheres. So that was the primary objective. And then the secondary objective was to look at all those objective overall response rates, the association between absorbed dose and overall survival, as well as tumor markers, using the Simplicity software for compartment dosimetry. In terms of patient baseline characteristics, 30% of patients were intermediate stage, and the majority of patients, 54.5%, were advanced stage HCC. You can see that about 70% had unilobar disease. And in terms of portal vascular invasion, 33% of the patient population for this study had portal vascular invasion. You can see a wide variety of cases, but just shy of 50% had tumors that were greater than 8 centimeters in size. So you're talking about very large tumors, aggressive tumor biology in this patient population. So what did they find in terms of the primary endpoint of looking for potential grade 3 hyperbilirubinemia or adverse events? Well, the primary endpoint actually was not met because the safety profile was better than anticipated. Only 4.8% of patients actually experienced equal to or greater than grade 3 hyperbilirubinemia. So the threshold to attain an endpoint at 15% was not even met. And what this shows is that TheraSphere is a therapy that goes preferentially to hypervascular tumor like HCC and spares the normal background tissue. And so it's a very safe treatment for the treatment of HCC. In terms of secondary endpoints, what they also found was that increased dose resulted in increased objective response rate. So again, it's not that you're trying to occlude the vessels, which is a little bit counterintuitive to chemoembolization. In terms of the catheter work, it may all be very similar, but the mechanism of action of destruction of tumor is quite different. And so because these spheres are going preferentially to hypervascular tumors, the absorbed dose rate correlated with an increased objective response and complete response rate. So the higher the dose, greater than 300, and the threshold here was 225 gray, the greater the response rates based on modified RECIST. And those who did not respond had a higher or a lower actually absorbed dose of about 188 gray. The objective response rate for the overall study was about 70%. And that is, to me, historically, when you look at chemoembolization data, you look at a wide range of studies, but if you do a meta-analysis, it's close to about 55% objective response rate. And that's really mostly limited to intermediate stage HCC. With this study, you saw real-world data reflecting close to 70%. So in summary, for the target study, no relationship was found between the grade 3 or higher hyperbilirubinemia, indicating a very safe profile for glass microspheres in the treatment of HCC. The objective response rate by modified RECIST for the overall study was about 70%, which is very impressive. And then tumor absorbed dose was independently associated with overall survival and indicated that a higher dose threshold was indicated for better response rates. And then lastly, the Dososphere study was a prospective phase 2 randomized control trial from Etienne Guerin out of France that looked at personalized dosimetry versus standard single compartment dosimetry in the treatment of advanced stage HCC. If you look at the screening criteria for these patients usually had very large HCC with portal vascular invasion and advanced stage. And this was published in the Lancet Gastroenterology, very respectable journal. The Legacy study, by the way, was also published recently in Hepatology, and they have yet to submit for the target study. But Dososphere study, the primary conclusion with this was that HCC patients who use personalized dosimetry and could target the portal vascular invasion component of this advanced stage population with tumor dose greater than 205 gray had a benefit in overall survival with a median overall survival of 26.6 months. Those who did not achieve the absorbed dose of greater than 205 gray or could not accurately target the portal vascular invasion, those patients had a median overall survival of 7.1 months. And so we're finding out more and more through these 3 studies that dose is extremely important for us to investigate and find out more and more. And we're finding out through these studies that it's an important component to include in the treatment of patients with HCC, as there is a benefit to objective response and a benefit with median overall survival. So in conclusion, LEGACY is a multi-center study affirming radiation segmentectomy, where you subselectively inject TheraSphere into 2 or fewer Cunode segments, is validated as a neoadjuvant or curative intent treatment for solitary HCC up to 8 centimeters in size, with a 400 gray threshold and an 88% objective response rate. The TARGET study, which is also a multi-center global study, reaffirms the safety of glass microspheres in treating HCC, as a relationship between grade 3 hyperbilirubinemia or greater was not shown as the primary endpoint, as it was below the threshold that was being sought. It's a multi-center real-world data confirming a significant association between tumor-absorbed dose and objective response, as well as tumor-absorbed dose and overall survival in HCC. And lastly, DosaSphere study was a prospective randomized controlled trial demonstrating advantage of personalized dosimetry when it's greater than 205 gray to the target tissue and PVT, with a survival advantage of 26.6 months. Thank you. And it's my pleasure to now transition to Sam Mooley, who will talk about exciting advances outside of the liver.
Yeah.
Thank
you, Dr. King. Yeah, it's beautiful. Yeah, Dr. King showed us 3 clinical trials. So we'll discuss later. Now the third speak is the SI abstract of the year, the novel use of the Y90, presented by Dr. Maureen from Northwestern University of Chicago. Please, Dr. Maureen.
Thank you for the introduction. So this is just a review of the data that we presented at the Society of Interventional Radiology meeting in March of 2021. And so this was a preclinical study looking at the use of Y90 radioembolization for proof of concept in a canine model for prostate cancer. So in the US, there's about 190,000 cases of prostate cancer a year. And for the last 30 years, the options for treatment have been surgery, radiotherapy, or active surveillance. And a large randomized controlled trial, the PROTECT trial, showed that there was no difference in prostate cancer specific mortality, overall mortality, or metastases between surgery and radiotherapy. And so the challenge of oncologic approaches to prostate cancer are to achieve optimal tumor control while preserving a patient's urinary, GI, and sexual function. However, with the current standards of care, there are complications with both treatments. And so with no superior treatment option, the patients are really driven towards their treatment choice by a risks-benefits analysis of the complications of urinary, sexual dysfunction, and bowel dysfunction. And up to 60% of men regret the treatment they've chosen given the side effects that they have to endure. So with regards to radiotherapy, the current standards of care are external beam radiotherapy or brachytherapy, which is a schematic here from the literature. And basically what we found is with dose escalation, you can get improved survival in these patients. However, there is an increased incidence of grade 2 acute and late GI and GU toxicities. So this is life-altering hematuria, urinary frequency, urgency that might require catheterization. This is also diarrhea, proctitis, bleeding in the stool. Additionally, patients encounter erectile dysfunction from radiation to the neurovascular bundle, which is the arteries and nerves that supply the prostate and penile soft tissues that control erections. And so what we found is with improved tumor control, you get increased toxicity and decreased quality of life. And so these are just 3 radiotherapy schematics, brachytherapy, and external beam at the bottom. And basically the take-home point is in all of these treatment options, a high dose of radiation is delivered to the rectum, which we see here highlighted in red. So in this space, prostate embolization has been explored. for the treatment of prostate cancer. So papers in 2018 in JVIR for both bland embolization and chemoembolization have shown that both really don't work for prostate cancer. From a bland embolization standpoint, there was a viable cancer on all explant specimens in 12 patients that were treated. And from a chemoembolization standpoint, they had limited clinical success of 62%, with a biochemical failure rate of almost 20%, which is not acceptable by current urologic standards. So our hypothesis rather, was to see if we could combine our knowledge of benign embolization for BPH, so prostate artery embolization, with our knowledge of Y90. So really building on what Wayne and Ed Kim had mentioned in terms of our understanding of how it works in the liver, can we translate that to what we know about prostate embolization? And can we do something in the prostate cancer space that'll provide patients with an oncologic benefit? So what we learned in the liver was that external beam radiotherapy is limited by respiratory motion. You have to give fractionated treatments. There are dose limits. And it really is, limited by non-target radiation to the adjacent organs. However, Y90 we found is all of the studies that Dr. Kim mentioned, there's really a lot more that we can do. We can deliver much higher doses than what's seen with external beam radiotherapy. One therapy can be ablative, such as radiation segmentectomy. We're not really limited by location of adjacent organs, and vascular delivery permits surgical deposition of radiation. So in the prostate space, we know that prostate cancer is exquisitely sensitive to high doses of radiation delivered in the fewest possible treatments. However, as you can see here from these various radiation treatment plans, the current standard of care radiation is limited by organs in the surrounding area that are receiving high doses of radiation. So EBRT, or external beam radiotherapy, as it currently stands, is limited by gland size, so smaller prostate glands, fractionated treatments, and non-target radiation to the adjacent bladder, colon, penis, and also the neurovascular bundle. Theoretically, Y90 could have the advantages of one treatment could be ablative, much higher doses can be given. As I mentioned, the vascular delivery would provide surgical precision in where the radiation is deposited. We know from our experience in benign disease that we're not limited by gland size in terms of embolization. And given the radiopharmaceutical properties of Y90 that Wayne went over, we shouldn't be limited by location of the adjacent bladder, colon, penis, or neurovascular bundle due to the properties of Y90 and the limited penetration of the radiation from the microspheres. So to study this, we used a canine model, so 14 animals with a low dose group, a medium dose group, and a high dose group that we can see here what the ranges were. We wanted to demonstrate technical feasibility and safety, so we treated one half the prostate in these animals and used the other half as a control. We wanted to make sure that we could prevent non-target embolization. Now here's a schematic of a canine prostate on the left and then the human on the right. And as you can see, it's pretty similar anatomy, a lot of anastomoses to the rectum, the bladder, the penis. And so you have to prevent non-target embolization using the same strategies that you would use in a clinical case. And then also in this model, we wanted to check the effects of dose escalation on the adjacent organs at risk, which has really been the limitation of current radiotherapy. They can only go so high without significant damage to the surrounding organs. And so we wanted to see what the limits with Y90 might be. So these are just some representative images from our study. So PET MR on the left, and then we generated these dose curves on the right, just demonstrating where the Y90 deposited and what kind of doses we were delivering. And so in the 14 animals, we were technically successful in delivering our doses to all the animals. About 11 out of the 14, we had to use coil embolization for protective maneuvers, just like we would clinically. And as you can see, we had really good deposition of the Y90, which we could image on PET MRI within the treated half of the gland without any extra prostatic signal. And again, we were able to generate these dose maps. If you think back to the earlier slide that I showed you, this is all the radiation is focused within the treated half of the prostate gland with minimal radiation deposited in the surrounding tissues and the adjacent contralateral gland. So from these images, we were able to generate dose volume histograms. And basically the take home point is Y90's here on the left, a comparative study in the literature in an animal model with SBRT is on the right. And you want really good separation of these curves between the treated area, which is the dotted line here, and the untreated gland, which is the solid line, and then the urethra and rectum. And what we can see in our curves compared to the standard of care external beam is the rectal wall and penile bulb or urethra receive really high doses with external beam with a limit of 60 gray. And in this specific animal study, 12 out of 22 canines had to be sacrificed early because of grade 4 rectal toxicities from basically burning a hole in the rectum with doses approaching 50 to 60 gray. On MRI, over time, we saw progressive decreases in prostate volume, so 25% decrease in the low dose group, a 60% decrease in the treated hemisphere in the high dose group. There was no evidence of cavitary necrosis, and we saw no evidence of extraprostatic signal changes. From a clinical standpoint, there were no laboratory abnormalities in these animals, no GI or GU toxicities that we would see with typical radiotherapy, no rectal fibrosis or proctitis, no urinary issues, no evidence of urethral strictures, and no change in erectile function. And on pathology, we saw dose-dependent fibrosis and inflammation of the prostatic tissues that were treated. And interestingly, no fibrosis, inflammation, or damage to the adjacent neurovascular bundle, the bladder, the rectum, the penis, or the urethra. So these are just some representative images. So here's a 200 gray Y90 animal on the left and a similar canine study on the right, which was a 50 gray dose. We can see here, even with the microsphere adjacent to the nerves, we see neuronal preservation versus neuronal atrophy, which was seen in the SBRT model. As I mentioned, we got up to 200 gray in our animal cohort, which is equivalent to 400 gray with EBRT, no damage to the bladder, rectum, or neurovascular bundle. Whereas in the SBRT study in the same animal model, as I mentioned, 12 out of 22 canines were sacrificed due to rectal toxicity, and 40% of the animals had significant nerve damage in their neurovascular bundle tissue. And so what we were able to show is with Y90, we can deliver intraarterially, we can get sharp conformity of dose due to the limited penetration of the Y90. So this is just our example of our dose map on the left, and then comparing to external beam radiotherapy on the right. And you can see that the dose is focused in the prostate, and there's a very limited dose to the extraprostatic tissues as compared to the standard of care. So what have we achieved? We've shown that it's technically feasible and safe in an animal model. We can get dramatic gland shrinkage over a short period of time without significant clinical toxicities, as seen with current standards of care. No damage on pathology to the bladder, rectum, urethra, or neurovascular bundle. We can also image Y90 with PET MRI, which opens up the possibility for getting actual dosimetry of what is delivered to the prostate versus model-based estimates that are currently used with current standards of care for radiotherapy. So ideally, what we'd like to do is, go to a first-in-man trial in intermediate risk patients who would be potentially offered a single session therapy. So these are patients with a Gleason score of 7 or greater, a high PSA, and T2B or T2C disease. In a higher risk patients with a higher PSA and a greater Gleason score, this may be used in conjunction with external beam radiotherapy. So use external beam for the adjacent lymph nodes and then use Y90 as a boost to the prostate. We would like to compare biochemical response or PSA kinetics to what's the standard of care with external beam brachytherapy. Additionally, there's an opportunity to treat patients with large glands or baseline lower urinary tract symptoms. Currently, patients with a gland of greater than 60 grams are contraindicated for receiving radiotherapy, and they either have to undergo some alternative therapy or androgen deprivation to shrink their prostate down. And so we could treat those patients right away rather than waiting in that group. And so the idea would be to demonstrate feasibility and safety in these patient populations. And that's it. Thank you.
Thank you, Dr. Murray. Yeah, very interesting, exciting. So let's turn to the discussions. First of all, I would like a few questions for each speaker. The first question, to Dr. Murray. So the question is, how do you differentiate the effect of the internal radiation or embracing, effects on the liver tumor. I mean, for the sex fair, I mean, yes, still many people may believe that be partially, I mean, affected by the embolization instead of the radiation.
Oh, yeah, no, that's a very good question with respect to teasing apart, if I understand the question correctly, kind of teasing apart the difference between potential embolization effects versus, radiation effects. And I think what's critical specifically to TheraSphere being a very minimally embolic product, because we are loading high doses of radiation onto a very small amount of microspheres, is the fact that we minimize the potential for embolization effects. And in one of the slides, I showed where you can still see patency of the, of the tumor post administration. So there's still that potential there to be able to retreat that region with other liver-directed therapies, or even subsequent treatments of TheraSphere as well. So there definitely is an opportunity, for those types of retreatments, and it is because of the fact that there's a very minimally embolic load of the microspheres being used with TheraSphere.
Okay, thank you. So when perform the, the certain, would better keep the patterns of the tumor, the feeding artery.
Correct.
Yeah. The other question for you is so far the Y90 is the best isotope for the microsphere maybe, but some literature reported the other isotope like the HO, 166. So
Holmium, yes, yeah.
Yeah. What's your comment?
Yeah, no, I think there is a competitive product emerging from a European company, Querum, called, and it leverages the Holmium 166 isotope, and that is actually interesting technology from the perspective that Holmium is imageable from a spec perspective. So there's certainly that advantage, I guess, with that microsphere. But once again, when you look at the specific activity of that product relative to the glass, it's lower. So the embolic load for that product would be higher than what we see with TheraSphere. The other thing, as I pointed out with respect to Holmium, is its energy profile is not quite as high as yttrium. So it doesn't pack quite as much of a punch as what the Y90 microspheres would.
Okay, thank you. So may I have more question for Dr. Kim?
Yeah, sure. I have a question for Sam.
Okay.
In terms of yttrium-90, we have more and more mature data going over a decade. And the standard really for providing Y90 therapy is to map ahead of time. But I think a lot of that is because there are intrinsic shunts between HCC pathology, arterial venous or arterial portal shunting. I don't think that is the case with prostate. Can you elaborate? Would there be a
Sure.
need for something like mapping, maybe for dosimetry purposes or planning purposes, or could you bypass all of that and do dosimetry based on cross-sectional imaging like MRI or CT, or maybe even ultrasound? And what are you starting to elucidate kind of those thresholds when it comes to prostate?
Sure. So that's a great question. I think that's the one thing that everybody's wondering. Do you need to do MAA for this? And I think those who do prostate embolizations for benign disease know that you don't really want to go in more than you have to, because it can be very technically challenging as a case to begin with. What we know from prostate cancer is it is not a cancer that shunts. So there shouldn't be arterial venous shunting. And additionally, another benefit is the volume of treatment that we would be administering in a theoretical model, even with glands that are 200 grams in size, the radiation doses we would be hitting, we would never reach our threshold, even if there was shunting, for a pulmonary toxicity. And so given those two factors, MAA is probably not needed in terms of mapping for shunting. Do you need to do mapping from a pre-procedural standpoint to determine what your dosimetry might be? Absolutely. So what I envision, which is currently what the workflow is for prostate cancer standard of care, is everybody's getting a prostate MRI these days. So you would get a prostate MRI, probably a CTA of the pelvis also to look at what the vascular anatomy is, and use those in conjunction with some kind of planning software, some future version of Simplicity or something along those lines to decide, exactly what kind of dosimetry you'd be giving, a 1 GBQ dose file on the right, maybe a 2 on the left, something like that, depending on the volume of tissue that you need to treat. So there'd certainly be a mapping component, but it would not be as technically arduous as it currently is for the liver.
And Dr. Mullet, I also have a question. I presented data, and there has been other papers, for instance, Mazzaferro, that shows high dose or greater than 500 gray, eliciting a higher objective response rate, and lots of radiation segmentectomy and portal vein invasion data that shows that higher doses lead to actually better outcomes, as long as those high dose thresholds are preferentially to hypervascular tumors or injected in a subselective fashion. That's the clinical data. Can you maybe explain the basic science behind giving that high dose? Because many people out there think it's dangerous to give such high doses to the liver or to a certain area. Can you talk about the basic science behind that?
Yeah, no, that's a very important point, and the inherent advantage of this type of approach where we're doing very selective internal radiotherapy. So as you mentioned, Dr. Kim, there's a number of publications which are showing, especially relative to external beam, just exorbitantly high radiation doses that patients would be receiving. But once again, the important point, as you elegantly mentioned, is the fact that that's done in a very selective manner. So we're taking all that high energy, ionizing energy that's coming from the radioisotope, and we're depositing that energy into a very selective region, which is contained around the tumor itself. So that's inherently the advantage of this approach and its capability to be able to take those high doses of radiation energy and deposit it into a specific region where the tumor's tissue is located. And that's very sparing, towards the normal surrounding tissue of it.
Okay, I will follow Dr. King's question for the radiation dosimetry. Dr. King showed us 3 clinical trial: Legacy, Target, and this fair. In these 3 different trial, the Legacy is prospective for the small tumor. Actually, most tumor, they're smaller than 3 centimeters. And the Target study is a retrospective real-world study. Is most tumor around 8 centimeters, large enough. And the last, the third trial is a dose phase. This shows us the dosimetry dosimetry dependent of the person's dosimetry, right? So yeah, I found that the Legacy study, the best the dosimetry seems like over the 400 gray, right? And the Target study are like more than 225 gray. Those fair like more than 200 is more than 200 gray. My question is still, the Legacy study, the tumor is so small enough, you have 400 gray. But the Target study, the tumor, in terms of the volume of tumor, might be 10 or 20 times than the Legacy study. That be only 200 gray. And so, if we, based on the Legacy study for the small tumor, 400 gray, that be for Target study, like we can use 1,000 or more gray. That be dangerous. Yeah. So how to explain it?
Yeah, so I think that because of the retrospective sometimes nature of the Legacy and Target studies, it's hard to look at and compare the two. I think many of us have experience treating HCC, and then when you see larger HCCs, let's say 8 centimeters, sometimes we treat 50. I'm sure our colleagues in China and the United States and around the globe see 15, 18 centimeter HCCs. I think as the HCCs get larger, we see changes in the architecture within the HCC where there is not uniform distribution, but a heterogeneous distribution throughout that HCC. In a smaller tumor, I think it is more of a homogeneous architecture and homogeneous enhancement that you can achieve very high doses to that area. I think the advantage of internal radiation is that you can achieve high doses that external beam cannot achieve. I think, though, the struggle or the obstacles that come with internal radiation is that we need to really understand the arterial inflow. As larger tumors and PVTs, there becomes preferential flow to one area of the tumor versus another. And so that can create hot deposition of radioisotope, for instance, in one portion of the tumor, and maybe less isotope in another. And so that could potentially lead to, in larger tumors, not as high deposition, depending on how you administered your dose. However, based on these two studies, I would say that we are more and more feeling comfortable dosing definitely above 200 gray to the absorbed dose to tumor, if not 400 gray. And I think that will change the paradigm in terms of how we treat, because we're going to probably treat with higher and higher doses to achieve better results, as long as it's in a controlled and selective fashion to mostly tumor and sparing the background liver.
Okay, thank you. You know, it's almost time to finish our the session, but I would like to have a privilege for myself for last question. Okay, the question is, you know, for the larger tumor, like you just say in my country that most tumor will be big enough. I mean, for most procedure, for certain, that be just one set. For larger tumor, could it be twice? I mean, the second set, or only, because, you know, based on the radiation dosimetry, we can, you know, plus. So that could be second set or more set for larger tumor.
Could be. I think for larger tumors, I do think that their Y90 could be cost effective. CERT could be cost effective, and have might I say better results with increased pathologic necrosis that correlates with objective response. Yes, I do agree with that.
But I mean, increase the toxicity of the normal liver, for second or third.
No, I think that when Dr. actually Kim out of Seoul National University Hospital published a paper in JVIR on boosted dosimetry for large HCCs, showing not an increased toxicity, as he gave it with preferential flow to the tumor and spared background liver. And we see this a lot of times as large tumors are extremely hypervascular, that they will preferentially take the radioisotopes in the spheres, and the background liver on the angiography sometimes won't even be visualized. And so I do think multiple studies have actually shown that these large HCCs, dosaphere as well as target study, show that the serious adverse events are actually quite minimal.
Okay, still last question, but it's time, you know, to close the webinar. So, yeah, I mean, now three presenters this morning: Dr. Kim, Dr. Murray, Dr. Murray, and Dr. Murray. The legislators show us the science background for the Y90 and the clinical update, and also the new application of the prostate cancer. So it's very, exciting, and for our Chinese colleagues, I believe. Now we're still in the time to learn more about Y90. So this first, the session that'll be more. I wish there'll be more from SIO and Boston Scientific and many other resources to help us. Anyway, I believe most Chinese colleagues are prepared to accept such a treatment. Yeah, specifically, I thank you, Dr. Murray. They show our very early Chinese literature for the Y90. So actually, 20 years ago, we involved not only Y90 but also like P32 microsphere, something many other microspheres. But now finally we stopped because the very strict the registration from Chinese FDA. So now none of the radiation microsphere in China marketing so far. So we're hopefully there'll be Y90 they'll be coming to China finally. So thank you so much. Thank you, SIO. Thank you, Boston Scientific, for bringing us the new knowledge for the liver tumor, for the prostate cancer, for the many other applications in the near future. So thank you. Good night.
Thank you, everyone.
Good day.
Have a good weekend.
Yeah,
Take care.
good weekend.